the webinar function of Zoom, and as a result of that, you have less ability to post comments. But I will be watching both the chat and the question and answer box. And at the end, we will have time for us to address any questions or concern you might have. Therefore, I'd ask if you have a question or concern, please type them into the boxes rather than trying to speak them. For those who are listening on the phone, the attendance code is CH Charlie, I don't know what H stands for, oh, Hilo or something, 1729. So without further ado, Dr. Mertz, I think is known to everybody. This is the third time he's done grand rounds in the last 6 months, setting some kind of a record. Dominic has become a thought leader in COVID, both locally and provincially and nationally. And his previous updates have been extremely well received. And he and I've had a bit of a chat about what's going on in the COVID world. And I think he's got lots more interesting and exciting news for us. So I'll turn it over to Dr. Mertz.
Yeah, thanks, Mark. Happy to be here again. So I was tasked summarizing the last 9 months, the knowns and unknowns. And these are the things I will try to focus on. So recap the timelines quickly, talk about the extent of the global spread, then showing you 6 countries with 6 different epi curves, have a closer look at non-pharmaceutical interventions and super spreader events, then go through a few frequently asked questions, and then a few slides on vaccines. I have nothing to declare in terms of conflict of interest, but I have to admit there will be some cherry picking happening. There's no way around it when you're looking at the number of COVID publications, which are now at 55,000. And in the last 7 days alone, there were 1,886 publications. Whenever I cherry pick, you will see this cherry pick icon. So you know I intentionally cherry picked, and what I typically did, I cherry picked to support one argument and to support the counter argument. So you get an idea of the level of uncertainty we are still moving in. I showed this table before. I will not spend any more time here other than reminding you that COVID-19 or SARS-CoV-2 is not the only coronavirus out there. And the big question really is, will COVID-19 eventually be number 5 of our common coronaviruses? So going back in time, Wuhan, as you can probably remember, large city, central China, the capital of Hubei province, which has a population of almost 60 million. The impact of COVID-19 to date, 68,000 cases, 4,500 deaths, a case fatality rate of 6.6%, very similar to what we have in Canada, actually, and I will come back to that. This is the timeline from an early New England Journal of Medicine paper, just reminding you, end of January, there was, or they identified several cases of pneumonia linked to the Huanan seafood wholesale market. Up to end of January, more than half of the cases had a link. After that, it dropped very quickly. The new virus was identified here on January the 9th. PCR became available. We had the first case outside of China reported on January the 13th, outside of Wuhan here on the 19th. But there's more, and I don't go through those studies in details here, but as I mentioned, the first known case outside of Canada and of China was in Thailand on the 13th. But based on wastewater studies in Italy, they identified in the PCR from wastewater in mid-December in Milan, as well as in Torino and later on in Bologna, that SARS-CoV-2 was already there. The first case in France, in retrospect, was identified end of December here. So, and then another wastewater study in Spain, which again showed PCR positive water samples well ahead of when the first case in Spain was identified. So bottom line is, even if you closed all the borders end of January, we probably wouldn't have prevented it to spread globally because it already did. So how does the global epidemiology look like? This is from a couple days ago, 25,500,000 leading led by the US, as you probably know, with 6 million cases, Brazil 3.9 million, India 3.6 million. And this is the global epi curve. There's nothing suggesting that the first wave is over from a global perspective. The big question is, may this be the peak from a global perspective, or will it continue to rise? And just based on population, probably what happens in India will be the most important factor here, because if it continues to increase significantly in India from a global perspective, the case count will continue to rise. Another way to look at the global epidemiology is breaking it down and normalizing by population. So what I added here is the current case counts per 100,000 population per week. And here you can see that Peru has the highest of those countries with the highest case numbers, with 160 per 100,000 per week. India, for example, is doing quite well with 37, despite the fact that they have very high numbers, but they have very high numbers because of the very large population, obviously. The US continues to come down, was sitting at 90 back then. A country like Pakistan, on the other hand, has a very low count with 1.4. Global deaths, 850,000, and you can see here the case fatality rate added. Globally, we are at 3.3%, ranging from 3% in the US up to 13.2% in Italy, among those countries with the highest number of deaths. And I will come back to that later. That's more a teaser at this point. This is our epi curve in Canada. As you know, we have our peak mid-April. Things are, from a national perspective, more or less stable since there was this mini peak here beginning of July. But other than that, things remain relatively stable. When you're looking at the province level, you see that Quebec with 62,000, Ontario is 42,000 are the leading provinces. On the right-hand side, you see a table which shows you again the weekly cases per 100,000, and here the lead is still with Alberta, which first had a significant increase in Edmonton and in the meantime in Calgary as well, while Edmonton seems to get better. Manitoba with 16.1. And you also see the RT, so your reproductive number estimated over the previous 5 days. And when you're looking at that, again, Alberta sticks out with, Newfoundland as well, but mostly Alberta with 1.26. Newfoundland has very small numbers, so you get a large RT based on just a single case that would be increasing. Ontario sits at 5.6 and relatively stable. This is our epi curve in Ontario, very similar to what you saw at the Canadian level, peaked beginning of April. What I wanted to draw your attention to are the color codes here. The blue bars are cases that were close contact or outbreak related. The concerning color is the brown cases. Brown means that it's unclear where they picked up COVID-19, which means that there's a source out there that's unknown. Travel, given all the travel restrictions, pretty much irrelevant these days. This is our Hamilton epi curve, and this is a cumulative number of cases figure, as you can see. I added here like pseudo regression lines. So these are 3 parallel lines. Just to give you a clue where we are sitting at in terms of number of new cases per day. And I'm on the record back here, April, May, where I said things are probably not getting much better than where we currently sit at. That was when we had 3 to 4 cases per day on average. Then the Roslin happened and we saw an increase of cases over a short period of time. Then we went back into a very similar equilibrium until finally we were entering stage 2 in a situation similar to where we had been before the Roslin. And then what happened during stage 2, in fact, was that our number of new cases dropped to on average 1 to 2 cases per day. During that time period, mandatory masking was introduced, and then stage 3 a week later. And then a couple of weeks later, I would say, since then, we are in a similar scenario again as before stage 2 and as before the Roslin, where we are sitting at around 4 new cases per day. Epi curves come in very different shapes and forms, and eventually, based on the example of the US versus Canada, I come up with some hypothesis what may explain these different shapes and forms. What I would like to show you is it's not as easy as A results in B. So the UK here, you see the number of new cases per day on the top in purple. You may see in green the deaths, and in blue the hospitalized patients, and here below you see the reproductive number, and at the bottom you can see at the very high level the policy decisions made in terms of lockdown measures. Now the UK continues to get criticized because they reacted too late, but when you're looking at the date when they introduced the lockdown measures versus when they hit their peak, they weren't that late, in fact, with the caveat that they may have missed a lot of cases, and very likely the number of cases here, in particular early during the pandemic, is heavily underestimated. But when you're looking, for example, at Switzerland, where the lockdown measures were actually put in place when they were already at peak activity, but had a much shorter peak than the UK had, and actually reopened most of the lockdown measures mid-May, including reopening schools, and nothing happened after that. So just the timing of the lockdown per se may or may not have made a difference, I would say. Switzerland is one of the European countries that since beginning of July starts to climb in terms of number of cases. Sweden, the other very heavily criticized country in Europe, because they opted not to do a lockdown and pretty much went right away to a stage 3 type of intervention with social distancing. They only closed up high schools. It's not that they didn't do anything, but they pretty much moved from nothing to a stage 3 kind of intervention. They didn't have a peak, I would say. They were on a continuous burn. There's a pseudo peak here in June, which was mostly because of increase in testing. But you can also see that now the number of cases are coming down. Mortality was very high in the beginning, and they had a similar issue with long-term care facilities as we had in Ontario and Quebec. And since you can see mortality is coming down as well. France, another example where there was a peak. They had a relatively early, pretty significant lockdown. They curbed the first peak here. Again, similar to Switzerland, they reopened mid-May, including schools. Nothing happened until July. And since July, the number of cases are increasing quite significantly, with now, for example, in the Ile-de-Paris, it now introduced masking even out in public as a countermeasure to that, but didn't went back to lockdown at this point of time. So as you can see, it's not as simple as if you do lockdown, then X happens when you compare the long peak in the UK with up to 2 months versus the peak that you saw, for example, in Switzerland. And then you have countries like France, Spain similar, that have a significant increase now over the summer, while others like Sweden don't have that. So it's not as simple to explain. Another question that I get asked very frequently is, well, why do we have this disconnect between an increase in number of cases and no increase in mortality, which I called here the new infection versus mortality gap? I use a logarithmic figure here showing you again in purple the number of new cases here in France, and green the number of deaths. And you can also see the RT curves here. And what you can obviously see that starting July, the RT of the purple line, so the number of cases, started to increase, and the RT currently sits for a prolonged period of time around 1.3. So one person on average infects 1.3 others. My mortality stayed relatively stable despite that. And there's three potential explanations to that. There's probably more, but the most common ones is that there's always a gap between time of diagnosis to death. So typically your death peak is 2 to 3 weeks behind your case peak. So that's certainly always something to keep in mind when you're early in a peak. Then it depends heavily on the population effect. And now obviously, and that's not very different in Europe than what we see here in Canada. Currently, it's mostly the young and otherwise healthy who get infected, which doesn't have a huge impact on mortality as compared to when you have long-term care facility outbreaks. And then the third hypothesis, and it is a hypothesis at this point of time, is that there might be a dose response effect. So the lower the dose you get infected with, the milder the disease. And then the theory behind it is, with the masking and the social distancing, that we on average get exposed to smaller amounts of COVID, we can better deal with it and resulting in milder disease. More to come on this topic for sure. Now, as promised, the US here, and Canadians tend to compare themselves to the US, although I think there's probably other countries that are more comparable when it comes to COVID-19. But here we go. On the left-hand side, you see the epicurve of Canada, and on the right-hand side, the US. And I added a red line here, which shows you the trajectory into beginning mid-June. And what you can see here in Canada, we had a clear peak and we had a clear decline after that, while in the US as a whole, there wasn't a clear first peak, there wasn't a clear decline after that, but there, of course, is a very significant second peak. And now you can hypothesize as to why this may be the case. And I listed 8 or 9 hypotheses here if you're considering plain luck as a hypothesis. But the hypothesis you often hear is it about differences in leadership? And I probably don't have to name any specific people here. Is it about less non-pharmaceutical interventions in the US? Well, it's not as easy. There's many states that actually have more severe measures in place currently than Canada has. Maybe the Canadians are just better rule followers and it's more about behavior than about policy. It may well be that the US had a much higher burden up front, and as such, it was simply not possible to reduce the case count as significant as Canada did. Maybe it was too early for reopening in the US, at least in many states. Then for the Sun Belt, it's important to say that this is the indoor season in the South, similar to what we will head into now this winter, and this may have contributed. We well know that indoor activity is much more dangerous than outdoor activity. Is it differences in population density or socioeconomic determinants? Or is it just more super spreader events in the US? And obviously I don't have the answer to that, but I will go into two of those hypotheses in more detail. But I will also want to make one thing very clear, and of course I cherry-picked just 2 states to show the contrast here. The US is a very heterogeneous accumulation of states, I would say. And on the left-hand side, you see New York City with this large first outbreak beginning end of March, beginning of April, and pretty much a flat line since July. While on the right-hand side, you see Florida, which was said to have done very well during the first peak, which wasn't really a peak, and then very heavily hit now over July, August. So the US, similar to what we see in Canada, but to a much more extent, much more heterogeneous in terms of what happened. So the two things I want to shed some more light on is the non-pharmaceutical interventions in the US. And again, heavy cherry picking by me here to show you the uncertainty when you're looking at modeling studies here, which non-pharmaceutical public health interventions work and which don't. The first study is a Canadian study where they looked at what do we require to do to prevent a second wave that results in significant surge of our healthcare system. And they compared minimal control, where they concluded the total attack rate of our population will be 56%. If we only maintained physical distancing, 41%. If we enhanced case detection and contact tracing, we dropped down to 0.36%. If we combine that with maintained physical distancing, 0.25%, and they concluded that only with this combination, we will stay with the number of cases that require ICU care below what we can actually handle with our ICUs. And they also concluded that there's only a minimal effect of school closures, but that closures of workplaces reduce attack rates significantly. Now, the other study from Europe, where they combined the ecologic data from 41 countries, they looked at each country, when did they introduce mask wearing, if so, when did they reduce gatherings to less than 1,000, less to 100, when did they close schools, when did they reopen, and so on. And that's what they found. So they concluded mask wearing mandatory in some public spaces reduces the R, so they used the reproductive number here, only very minor, if at all, by 2%, similar to gatherings limited to 1,000 people or less, not a huge impact. Once you reduce gatherings to less than 100 or then less to 10, you see a reduction in the R in the range of 40%. Whether you close some businesses or most non-essential businesses doesn't make an awful lot of a difference and has a similar impact as limiting gatherings to 10 or less. Schools and university closed showed here a very significant effect with 40%. Stay-at-home orders, less of an impact, roughly 20%. Now, obviously, there's a very mixed message about whether closing schools have an impact on community transmission or not. But then the other piece that certainly stands out is mask wearing, and I can easily pull some other modeling studies. There are dozens or probably hundreds out there, which would show you a very different picture, that mandatory masking would reduce your R much more significantly. This is just one example that I pulled, where you can see that they estimated, even if with an effectiveness of masks of only 25 to 50%, that your R would get reduced by 30 to 40%. So lots of unknowns. Now, you can go further with the cherry picking when you talk about masks, and I use the cherry picking by Globe and Mail here, where they summarized several countries across the globe and what their mask mandates look like. You see here countries with a federal mandate of masking, then countries like Canada, where the masking is at the provincial or even smaller units or municipalities deciding on mandatory masking. And then you have countries, mostly the Scandinavian countries plus Finland and Iceland, which don't have mandates. And now it's easy to pick two of the two extremes here. So let's say federal mandates we have in Spain and in Vietnam. Spain is up here, hit very severely by the second wave despite universal masking or mandated masking. On the other hand, you have Vietnam, where they hardly know what COVID is, and they have mandatory masking. And when you're looking at those with no mandates, again, Norway is doing very well despite not mandating masks, while Sweden isn't doing as well. at least not in the beginning of the pandemic, but again, many other differences. So bottom line here is, it's not as easy as saying, if you do A, which in this case is mask, B is going to happen. The situation is much more complex than that. Now, the second aspect or hypothesis I want to go into more details are superspreader events. I couldn't find a clear definition of what a superspreader event is. To me, it's events with one or more index cases resulting in a large number of secondary cases. And there's, at least in theory, many contributing factors that can contribute to a superspreader event. So one is supershedders. There's a theory that the sources of those events are mostly those that shed more virus. We know that there are people out there who shed more virus, but the link has never been shown yet. It's mostly the young and asymptomatic. And that's the case because, well, if you're asymptomatic or only have few symptoms, you may still go out and party, and that's when you see those super spreader events happening. On the other hand, we know that if you're symptomatic, and it seems like the more symptomatic you are, the more likely you are to transmit within a given setting. And then those super spreader events usually need a large number of people, of close contacts, and your super spreaders are very social people, because if you're sitting in front of your computer and play Fortnite, you're not going to trigger a super spreader event. And then the typical setting for super spreader events are indoors, crowded, with insufficient ventilation. And maybe the Huanan seafood, in hindsight, wasn't the source at all. It may just have been the first super spreader event which made us aware of this virus. And there's a lot of publications and a lot of reports in the lay media about super spreader events. And I could go on and on going through all those events. And there's also modeling studies, again, looking at that so-called over-dispersion, which means that you have a very small, or you have a relatively small number of people being responsible for the vast majority of transmissions. And in this paper here, they concluded that 10% of individuals are responsible for 80% of secondary transmissions. So I wanted to look at the current epidemiology and to what extent outbreaks, which may be a good measure for super spreader events, how often that happens. And I just picked a couple of states in the US because the data was easily available to me. Here, Louisiana first, and they saw 41 bar outbreaks with 468 cases, food processing, 27 outbreaks, 735 cases, and in the industrial setting, again, 402 cases. So a total of 2,600 cases related to outbreaks. Now, if you put that into the context of the number of cases they see in Louisiana, out of those 150,000 cases, then you realize, oh, outbreak related are only 1.8% of cases. Now, of course, every case from an outbreak may result in secondary cases, so may trigger more cases than what you see on this table, but still, it's a very small proportion and only 1.5% of death. Similar picture when you're looking here at San Diego, 238 outbreaks, 1,600 cases here, and clearly restaurant bars sticking out here. And as you know, many people would say, yeah, close those bars and restaurants to keep us safe. Here, San Diego has 38,000 cases to date, so outbreak related were 4.3%, so still a relatively small number. However, to have an outbreak, you need to have those facilities opened, which is the case here in San Diego, where business were opening before the second peak here. So during the second peak, all of those were at least initially open. So those outbreaks actually could have happened. And I show you data from Switzerland as well. Unfortunately, that's in German here. First of all, the concerning piece here is that in 40% of cases, they didn't know, or it remained unclear what the source was. But in those where the source or the index was clear, it's first and foremost family members, 27%. 8.7% were at work, then followed by private parties, and only then you see disco club, bar, restaurants listed with somewhere between 1.6 and 1.9%. And this was during the time period that the number of cases started to pick up in Switzerland. So it's relatively small numbers, but still showing you a similar picture to what you saw in the US states. When you look at the Hamilton Public Health website, they currently have a glitch there, so don't trust what you see, because it would suggest that out of all the cases in the last 10 days, 81% were community acquired, which means that they didn't know where it came from. So that's not true. What I was told is that the vast majority of cases are still within families and within clusters or bubbles, and it's mostly due to behavior and not due to reopening policies. No outbreaks in restaurants or bars or gyms at this point of time. Households. I just added this here, another preprint of a systematic review of household transmissions. On the left-hand side, you see the difference between a symptomatic household member and an asymptomatic. With a symptomatic, 20% of household members got infected. With asymptomatic, in this data here, it was close to 0. On the right-hand side, you see the comparison between household contacts and family contacts, not as important, but when you're looking here, again, it's roughly 19%. So 1 in 5 family member overall gets infected. But on the other hand, and again, I said that I will cherry pick from both extremes. There's certainly also data that suggests that superspreader events are highly important in terms of triggering community transmission. And this here is from the very early days in Japan, where they had a cluster of more than 100 people getting infected, or at least associated with several music clubs in Osaka. It's a preprint, so the figure doesn't look great, but what you can see here is the orange line, which is the daily number of diagnoses in Osaka, Hyoko, and Kyoto. And the blue line are the number of cases that were associated with this cluster. And you can see that early in the outbreak here, pretty much all the cases were explained by that cluster. Now, this may be because actually, in truth, the only major event of transmission that happened was this cluster, or B, given it was early in the pandemic, that's what they really targeted in terms of testing, and there might have been many other people out there that they didn't pick up at this point of time. This will remain unclear. But bottom line is, when we look at what we know and what we don't know yet, is that modeling studies and media reports certainly suggest superspreader events may be a main driver of local epidemiology, but new epidemiologic data isn't necessarily supporting this notion. They do occur, they can contribute, that's for sure, but they are not necessarily the main driver. And just closing up the bars again will not solve the issue when we see an increase in cases. It's more about behavior and what people do on a daily basis and the private parties. Next topic, kids in schools, probably after masking the second most contentious topic. And I had to show that from the New York Times a couple days ago, one of those very, I would say, alarmistic articles where you look at those figures and you're like, oh gosh, what's happening? Our children are at very high risk. 7 times more cases, 3.5 times more hospitalizations, and double the number of deaths as compared to May. Now, if once you take a step back, you ask yourself, well, what's the y-axis? Probably percentage. What's the baseline? We don't know. What are the absolute numbers? We don't know. These are the absolute numbers. And when you're looking here at end of August, out of 152,000 total deaths in those 43 states and New York City here, they had 101 child deaths. So children were responsible for 0.07% of all deaths, and 0.02 of infected children died, which actually is lower than how it looked like back in May, where it was at 0.06%. So just a reminder that when you're looking at statistics, in particular in the lay media, always ask yourself, do I have all the information I need to really interpret what they want to show us? Another set of cherry picking here, just to show you the uncertainty again, a federal document on COVID-19 and children and the Ontario Science Table report that came out a few days ago. And these are the conclusions here. The feds concluded that younger children up to 10 years of age seem to have lower infection rates than older children, that younger children do not appear to be important vectors of COVID-19 transmission, unlike, for example, seasonal flu, and that it's not possible at this point of time to establish a cutoff when children have the same level of infectivity and transmission as adults. While the science table in Ontario concluded that for children younger than 10 years, it's uncertain whether they are less likely to get infected, uncertain whether they are less likely to shed the virus or that they infect others. The only agreement, I would say, between the key messages of those two documents is that children tend to be more frequently asymptomatic and typically have a milder course. So I stop here on this topic. I just wanted to reiterate again that on this topic of kids, school, and to what extent kids transmit the virus, there's no clear evidence that points to the left or to the right, and it's to a large extent down to interpretation of very limited data, typically case series and so on, which explains why different groups of people may come to different conclusions looking at the same data. I was asked to talk about air travel, and there's certainly several case reports out there of likely or possible transmission on airplanes, and which wouldn't come as a surprise given that it hits actually all the three C's. So it's close spaces, crowded places, it's close contact settings, and it's actually also the fourth C if you want to add that over a prolonged period or continuous time. But when you look into it in more detail, despite all those case reports of transmissions and the daily reports of COVID-19 passengers that you see in the media over and over again, most contact tracings do not identify transmission. And the hypotheses are that this is because of the efficient ventilation system you have in an airplane, which is similar to what you would have in an OR or in an airborne infection isolation room. And then you have the cleaning protocols, hand sanitizers. Most airlines are requiring masks as well. But you don't see those published, of course. There's one exception to that rule, Kevin Schwartz's paper here, looking at the first two cases that were imported to Toronto, that couple that traveled by airplane, and at least one of them was symptomatic at this point, where there was zero transmission on that flight. Which brings us to the next topic, serology studies. And that's really the question about what proportion of the iceberg, or what's the tip of the iceberg we see by analyzing the tip of our NPS swabs. And you're probably aware of the Canadian data here. So the BC study showing age standardized seropositivity of less than 1%, 8 times higher than what was known based on NPS testing. The Ontario data, again, 1.1% adjusted rate of positivity, here 4 to 5 times higher than what was known based on PCR testing. And similar findings by the Canadian Blood Services, another study that's still ongoing, where they also found less than 1% of samples being positive. So we have a very low seroprevalence, which I think we expected. On the other hand, areas that were hit very badly by COVID, like New York City here, serologic studies show a very different picture. So here we have Bronx as the most heavily affected neighborhood with 33% positive, Manhattan less so with 19%. And no, it's actually true. There's one neighborhood that's called Corona, which happened to be the neighborhood with the highest seropositivity with 51.6%. And we are looking at Italy as the most heavily affected place, I would say, with northern Italy in Europe. And looking here at Lombardia in the north, 7.5% of those people were tested positive. They did a study of 64,000 people here in Italy. Across Italy, on average, it was 2.5%. In the south, with Sicilia, only 0.3%. They also found lower rates in kids and in the elderly population. And here it was 6 times higher than what was expected based on known PCR tests. And then the latest study, just published a couple of days ago from Iceland, they tested 30,000 people in Iceland, so that's roughly 10% of the population. The good news is here, 98% of those who had a positive PCR actually had a positive serology, and there was no decline in antibodies over the first 4 months. They estimated that 0.9% of Icelanders were infected, so very similar actually to what we found here in Canada. Roughly half of those infections were already known by PCR, so they didn't miss a lot of infections in Iceland. They only had 10 deaths, and they calculated an infection fatality rate of 0.3%, ranging from 0.1% in less than 70-year-olds to 4.5% in the older than 70 years old. This is an IFR that's lower than what you typically see, and we will come back to that. The bottom line here is serology identifies 2 to 10 times more cases than what you pick up with your NPS testing, but there's still a lot of limitations and unknowns here. So false negatives, you may have low and falling titers, although the Iceland study was more reassuring that at least over 4 months, in most cases, those titers remain detectable. There's still an unclear role of T-cell immunity here. Then you are at risk of false positive, given the very low pretest probability you have. Then it's always a question of generalizability and in particular representativeness if you have a very small subset of the entire population that you have access to. And then duration of protective immunity, or whether it is protective immunity to start with, is still unclear as well. Which brings us to how to measure mortality, and there's no single way that gives you the best possible picture, and my advice is look at all you can get. So just a reminder here, case fatality rate, CFR, infection fatality rate or ratio, IFR, and excess mortality. Into CFR, your denominator is known confirmed cases, so typically your NPS positives. Infection fatality ratio uses in the denominator what your estimated number or modeled number of infected cases is based on serology studies. And excess mortality is the deaths above and beyond what would be expected typically compared to the 5 years prior. Let's start off with the CFR, so the case fatality rate, where Canada sits in the 6% range, and actually similar to countries like Sweden, Chad, Egypt, Iran, and China, just to name a few. But on this chart, you also see that the case fatality ranges from less than 1% to close to 25%. So why this heterogeneity? It's the same virus after all, right? And some explanations for that are certainly maybe transparency or reliability of reporting COVID deaths. So there's certainly concerns, in particular in some jurisdictions, that not all cases get reported as such. Then it heavily depends, and I talked about this previously, on the population affected. So if you are in Quebec or Ontario, where we had significant impact on long-term care facilities, you see a higher fatality rate for either the case fatality rate or the overall infection fatality rate. Search of healthcare systems certainly doesn't help, and you will see additional preventable death. And case fatality rate specific, it's about criteria and capacity for testing, because the more you test, the more mild cases you find, the lower your CFR is, and the closer you get to the IFR. So talking about IFR and looking at Switzerland, which sits at a case fatality rate slightly higher than, slightly lower than Canada. And just to give you one example here, a study from Geneva, where they did a relatively large serologic study, showing you what you need to calculate an IFR. You need your population optimally by age group. You need to estimate your seroconverted population and your number of deaths per age group, and then you can calculate your IFR. Just to make it easier to read for you, so in the young, the rate was 2 in 100,000, in the middle age group around 1 in 10,000, and in the above than 65-year-olds, it's roughly 5%. Now, if you look further, and this is also a preprint here, where they used the Geneva data, but also data from Iceland and data from 39, I believe, other countries or jurisdictions, and they looked at the function of median age and infection fatality rate, you can see a very clear picture that the curve or the line really starts to increase significantly after age 55, and then after 75 it goes up and triples from 75 to 85. And what they did here is they compared the fatality rate to accidents annualized, but I would like to focus here on what they found in terms of infection fatality rate, which is slightly higher than what you saw in the Geneva data. So for the 0 to 34-year-olds, it's 1 in 10,000. Then for the around 60, it switches into the percentage rate range, and above 85, it's actually 1 in 3. And there's other comparison, as I said here, it's accidents. There's some weird comparisons. I just picked that up yesterday where someone said it's as dangerous as having a bath. So that's probably not a very helpful comparison here. Then another approach to measure death is excess death. And this is data from France here. Your red line is your baseline. The orange line is the upper 2 set score limit. So above that, you would say it's excess death. You see here in France, for the less than 15-year-olds, you actually had a decline in number of deaths, probably due to the fact that those kids stayed home more than they usually would, and less accidents and so on. No difference in the age group of 15 to 44, but above that, you can see a very clear peak, in particular in the more than 85-year-olds. In that age group, you see pretty much a peak every year. That's from flu, but the COVID peak is significantly higher. In absolute numbers, they found that there was 16.6% more deaths in the calendar weeks 10 to 22 during the first peak in France, a total of 25,000 people. 97.5% of those excess deaths were in people older than 65. Increases in general can be explained by, of course, deaths directly associated with COVID-19 and due to other conditions that were left untreated because of COVID, or people not daring to go into the hospital. And then, as I mentioned, a decrease can be explained, as in the youngest age group, by reducing other risk activities. And not in France, but other countries, you would see there's a large peak, and after that, actually, it drops below what would be expected, which can happen when you have people die because of COVID days or weeks before they would have died. So that may result in a reduction just after the peak. My last 4 slides, I need to wrap up here on COVID vaccines, and just really quickly, you're probably aware that Canada has now contracts with 4 vaccine manufacturers using 3 different approaches to a vaccine. two of them being currently in a phase 3 trial, a couple of them currently in a phase 2 trial. There's three vaccines that are currently approved or limited approved, two in China and one in Russia that's apparently being administered already, despite the fact that those vaccines are currently in a phase 3 study. This is the update from the New York Times. They concluded, though, 3 that are limited or approved at this point in China and Russia. There's 9 in phase 3, 14 in phase 2, and 23 in phase 1. What do we know about vaccines? So we know that SARS-CoV-2 has only rare and minor mutations. So from that perspective, we sort of expect that the vaccine may be able to work over prolonged periods of time, and that it may be less the scenario of flu, where every year we may need slightly different vaccines. But we obviously need immunity, which in this case is referred to as vaccine effectiveness, optimally to prevent transmission, which gives us herd immunity and may allow us to eradicate this thing eventually. It's well possible that we will not achieve that, but then hopefully we can at least prevent clinical infection so that people don't get sick, which would mean that, as I said, that COVID will become probably our 5th coronavirus, and we are protected from the vaccine. Or at the minimum, to prevent severe disease so that we still get sick, but we don't end up on the ICU or die. We know that there are several vaccine candidates that have a strong immune response in phase 1 and 2 studies, but we really require this clinical outcome data, which is the phase 3. And the same is true for safety. No safety concerns so far, but phase 1 and phase 2 studies are a very small number of people, so we need phase 3 and eventually phase 4 to make sure that those vaccines are safe. The unknowns here, we don't know for how long immunity will hold. We now have, I counted a total of 8 reinfections that have been reported, some questionable, but overall it seems like, yes, it actually can happen. Not sure how the vaccine will play into this. Then logistics, we would have to vaccinate 7.8 billion people, which obviously will be a major undertaking and will likely take years. So just because we may have a vaccine at hand beginning of 2021 doesn't mean we are out of this pandemic. And then the question, of course, is who to vaccinate first. Should we first vaccinate those at highest risk? So the elderly population and those with comorbidities. But that's a population that typically has the lowest response to vaccine, so may not be as beneficial as maybe vaccinating those with the highest response first and aiming for indirect protection of the vulnerable. Or should we do what China and Russia seems to do, to target high-risk professions first? So lots of unknowns. And my main goal with my presentation today was not to draw any firm conclusions on anything, and just to give you an idea of that the answers are very complex. And whenever you have someone tell you, well, if you do A, then B is going to happen, in general, that's wrong, because the answers are much more complex and there's still a lot of uncertainty out there. And we are on a journey to learn more and more, and we have to do our readings and we have to do our studies to eventually deal with this pandemic the best way possible. So thank you very much, and we still have some time left for questions. Back to you, Mark.
Thanks very much. And again, for those listening on the phone, the attendance code is CH1729. So we've got a bunch of questions here, and we'll try to run through as many as we can in the last 5 minutes, but we will finish right at 9. So the first one is, in Hamilton, we, Dr. Smia and colleagues changed our testing algorithm, and you can order SARS-CoV by itself in the viral NPS swab testing, or you can order the traditional multiviral NPS. Are we going to go back when we get into the cold and flu season again to having all viruses in the swab, or what are your recommendations around whether we should just order SARS-CoV or we should order the sort of multiple virus swab?
So first of all, the hope is that we will have the reagents back in October or November to be able to do the multiplex at a larger scale again. The reason why we have limited it right now is the fact that we can't, because we run out of reagents and we only have little left, which we need to use for those who really need the testing. It really depends on how our flu season will look like. When you're looking at New Zealand, Australia, there's not a lot of flu happening, and we need to see whether the same will hold true here, whether all the public health measures that we have in place will heavily affect flu as well and the other respiratory viruses. However, it looks like rhino and adenovirus, they still find their way to transmit despite all those measures. So we will have respiratory viruses around us. The big question is to what extent we will have flu, and flu will be the main reason to order the multiplex, because it has implications on management of the patients. But yeah, more to come. At this point, the hope is that we will have enough reagents so we can go back to the multiplex for, in particular, hospitalized patients with comorbidities.
Thank you. A question about schools. So if a school has an outbreak, is the idea that you do traditional contact tracing, or do you just shut down that group and sort of try to enforce restrictions on that class or that group of exposed people? Because the question is, do we have the capacity to do contact tracing in school outbreaks? But I guess the sub-question is, do we actually need to do that since we know where the exposure is?
Yeah, so the plan at this point is that probably in most situations, when you have a single case in a classroom, the whole class will be sent home. If you have an outbreak, so suspected or confirmed transmission in the school, and you will need to shut down either a class or an entire school, then everyone would have to go home for sure. It's well possible that how this will be managed may be different from health unit to health unit, because the interpretation of the documents around this is relatively broad. So, but my assumption from our discussions we had with our public health people is that most likely once you have a case in a classroom, the people of that class will have to stay home for 14 days.
Thank you. If a person comes into this is from Ann Holbrook, if a person comes into the hospital with typical symptoms and their initial swab is negative, can you comment on the sensitivity and specificity of our swab, and then the need for serial swabbing?
Yeah, it all goes down to your pretest probability, right? So if you are highly suspicious that someone has COVID-19 and you have one negative swab, then our usual recommendation is to re-swab. It looks like the sensitivity most likely sits around 90%. So of course you miss one or the other. So if you have a very high suspicion, we usually recommend to do a second swab, optimally a sputum, or in an intubated patient, an aspirate. Because what does happen is that the later in the course of the disease, it seems like the less reliable is our NPS testing, because the virus sort of travels down from the nose to the lungs, and then we would really like to have that deep sample.
There's a great podcast, for those of you who can't get enough coronavirus news, which I gave up on a long time ago, but if you want to listen to it, it's called TWIV, which is This Week in Virology, and it's actually really, really sensible. It's a long thing, and they were talking about this whole issue of sensitivity and specificity of varying tests on the podcast from last week. And if you really want to know a lot more about that, Anne, you should talk to them. They were really concerned about false positive rates and recommending doing 2 different tests if you get a positive in low prevalence states, because, you know, as you just pointed out, Dominic, if you're in the right population, the false positive rate is actually going to be a bigger problem than the false negative rate in some ways.
Yeah, I didn't mention that, but with the asymptomatic testing currently, it looks like the vast majority you pick up are either residuals from previous infections, so they can remain positives for weeks and months, but it doesn't mean that they are infectious at this point of time. And it looks like there's also the true false positives occurring occasionally. So it really goes down to the population you test. But if you have a high pretest probability, your main concern would be the false negatives rather than the false positives, and then there's certainly a benefit of retesting.
Thank you, Rich. Okay, so the last question, because it is 9 o'clock. What would your comment be about the European Centers for Disease Control extending the transmission period beyond 14 days?
I wasn't aware of that. I felt like most countries would have reduced from 14 days of isolating people down to 10, or some have even considered 7 days. So I need to look into that in more detail. Now, obviously, with all those arbitrary endpoints, there's always outliers, right? So if you go to 10 days, you will have more cases that may still be infectious after 10 days that you would sort of accept. If you have 14 days, then of course it's not entirely perfect. So it's really about balancing those pros and cons, and this is really one of the public health decisions. I get typically asked, when is Canada moving to 10 days? I haven't seen any signals of that. I assume that we will stick to 14 days for now, but I will look into the European CDC.
Great. Thanks very much, Dominic. So again, we'll end there. Dominic, thanks so much for being heroic and doing 3 sets of grand rounds in 6 months. This is some kind of record. You'll get an Academy Award for that, I'm sure. And thanks for a really level-headed, calm, and very scientifically based talk, which we've come to depend on from you. We'll probably have you back once more before Christmas, particularly if things heat up a little bit. So thanks very much, and everybody. And again, just for those who are asking, this will be available on the Department of Medicine YouTube page. It'll take us a little while to get there. To find that, you go to YouTube and type in Department of Medicine McMaster, and it'll pop up, and you'll see Dominic featured prominently there for his 2 previous talks as well. If you want a little historical nostalgia, go back to his first one, and you'll see where we could have been. And you listen to this one, and you see where we are, and you'll see that it's a very hopeful message if you're looking for hopeful messages in the year of despair known as 2020. So thanks very much, Dominic, and the attendees. Next week, rounds will be hosted by the 2 different hospitals, but we look forward to seeing you at rounds next week. Thanks very much, and have a great day.